Welcome everyone to the Understanding School-Based Mental Health and Medicaid webinar series. This 5-part series is designed to build a shared foundation of understanding how Medicaid supports mental health services in both school-based and community-based settings across the state of Illinois. The vision of this series is to support the provision of mental health services to students within school settings to reach all youth, and especially those that may be most vulnerable that cannot access services otherwise. My name is Matt Buckman. I'm a licensed clinical psychologist, duly credentialed as a school psychologist, and also the executive director of the Stress and Trauma Treatment Center. I will be guiding you through today's content and this 5-part series. This webinar was developed with support from the U.S. Department of Education's School-Based Mental Health Services Grant awarded to West 40 Intermediate Service Center No. 2 in partnership with the Stress and Trauma Treatment Center. This material is provided for educational purposes as a broad overview. It does not replace the official guidance from HHS, CMS, or the Illinois Department of Healthcare and Family Services. Regulations and compliance requirements can change, and participants should always consult authoritative sources. This is a 5-part series. This series progresses from foundational Medicaid concepts to increasingly more specific applications. Starting with a foundational understanding of Medicaid allows us to dive deeper into the school-based reimbursement system, community mental health services system and reimbursement for this, and specialized care coordination service organization and pathways programs. The final part of this series will be a discussion of ideas for action, which will build on the previous content and identify concrete steps or strategies to leverage funding to increase access to mental health services for students. Part 3, an overview of community-based mental health services in the state of Illinois. The agenda for this part is to look at the community partnership models and systems of care that individuals and families live in. We're going to talk about some of the Medicaid provider types and some of the Medicaid services and the types of services that are available that could be integrated, collaborated, or a partnership for the school district. What we know is that children don't grow up in a bubble. When we're looking at the whole child of our students within our school district, we know that they are tightly influenced by their family, friends, and close others. And there are systems or sectors within the community, within their environment, that do influence their success and their well-being, especially in when we're looking at mental health and mental wellness. We have a primary care system, we have mental health services and system, we have substance use services and systems, we have the school system, the district, the educational services, we have community programming supports, recreation, natural supports, faith-based services, vocational services, child welfare or DCFS, and juvenile justice and justice systems, as well as family court services. When we're looking at all of these different sectors and systems, sometimes what we find is that it's hard to break down barriers or to allow collaboration amongst these multiple sectors. But whenever it comes to families, and especially families and students with complex needs, they may have to navigate between all of these different systems and sectors that maybe there's different terminology used from one to another, or different eligibility from one to the other, different way or purpose of service, a way of services being provided. And so this is the complex system that many of our families, and especially the highest need individuals, live in. And so when we're looking at collaboration can be complicated. And so we're going to specifically look at the mental health system and how we're able to create integration or collaborative partnerships to be able to address the mental health needs of our students. First, let's take a look at the Illinois Interconnected Systems Model for School Mental Health. When we're looking at 100% of all students, all families, all school staff we need universal preventative types of efforts that can be helpful. And then with that 100% and any type of multi-tiered system, 80% of our students, the majority of our students will actually, that will be enough for them to be able to address their needs or intervene early enough or educate in a preventative measure, that 80% of their needs, of students' needs, will be met. And then for 20% of students, or 15%, depending on which model you're looking at, for about 20% of students, the universal supports were not enough. And so then we supplement, or bridge or expand or add in additional supports. And sometimes these are more group type of supports and services. Sometimes these are additional lessons that might be helpful around mental health needs or mental health supports or coping skills. Or maybe it's some brief intervention supports, one-on-one or group, either one, that start to address some of the needs. And we're hoping to intervene early enough that we're not looking at really intensive needs of these individuals to be able to provide those services to them. And then as we continue down that path, then you get into the 5% or so of students that need individualized services and supports. And in those individualized services and supports, we're now going into more intensive services. This is where very individualized treatment planning and service planning is happening. And those individuals are all receiving services and supports that are tailored to their individual needs. When we're thinking about how we're able to create this interconnected system or multi-tiered system of support for mental health needs, we're oftentimes trying to think of what resources do we have. And that I like the joke that, like, I don't have to own a boat. I just need to know someone who owns a boat. It's much better. I don't have the expenses, the maintenance, all that kind of stuff. And I can maybe have something that, is a trade-off between the two. But we don't have to be specialists in everything, but we all probably play a part in the facilitation of mental health wellness and mental health interventions for our students. And so when we're looking at our community partners, oftentimes their resources are very limited for tier one supports and services that might be out there for mental health. But then we're maybe matching with tier two, and that community partners and the district oftentimes have equal space in tier two, maybe more with the school district than it would be the community partner. And then the vast differences, again, like in tier one, is in tier three. Oftentimes, community partners are specifically working with individuals that already have a diagnosis, individuals that already need individualized or intensive types of supports. Maybe that's psychotherapy or therapeutic services that might be there, or counseling services. They might have intensive case management needs. Community partners oftentimes come with more resources and are oftentimes funded more for that type of activity, with very little funding in the area of preventative or sometimes even in early intervention types of supports. When we're thinking about a multi-tiered system of support for mental health, we can both consider what do we do in-house and what do we do out of the house, right? So what do we bring in a partner for? And sometimes maybe it's we're providing a certain amount. Maybe it's minutes. Oftentimes dosage might be something we're considering. Maybe it's a number of minutes, or maybe it's a certain type of support or service. And then to supplement that is also a community partner. And then sometimes it gets so complicated, we let the community partner be the primary provider, and then we're providing kind of additional or secondary supports. Or maybe we're focused on the school environment and they're focused on the broader, maybe, or even home environment that might require their expertise. And every school district, just so you know, I don't expect that one school district's expertise is exactly the same as another school district. And so maybe the school district has certain expertise and that's what we keep in-house. And then just based on the expertise of our staff, we may not have that in another school district. And that's where we want to bring in community partners. And then sometimes we're just sharing the caseload or sharing the amount of students where it's one for you, one for us, one for you, one for us. And we're just trying to, as a community, come together and provide the supports and services that are necessary. But there are certain things that we may find outside mental health staff and or organizations can bring to our district that perhaps we don't have the capacity for, the want for, or don't want the liability for, or whatever reason it might be, that we're going to address the things we can in the ways we know is our scope within the school district, and then add in partners as necessary. One organization or type of organization that takes Medicaid and serves youth and students with Medicaid are federally qualified health centers or rural health clinics. These providers oftentimes have a comprehensive array of services. Some might even have dental services. They have mental health services integrated with primary care, physical health services, and perhaps many other types of offerings that may be there. These providers are able to provide services in their established clinic locations. And so oftentimes they're not able to go into schools unless they have a clinic there in the schools. Some of these entities might be managing a school-based health center. One of the unique aspects of it is that the providers that are going to be there are oftentimes licensed mental health or physical health providers. It's an integrated care model, so there's collaboration with the primary care provider or physician with the behavioral health provider. The system of payments that are used in this one is a little bit different than a fee-for-service system in that it's a prospective payment system. Which is going to be the average kind of cost according to all of their cost reporting. And so each event that occurs, and these are just some rates that are online that you can find through HFS, but each event that occurs is about $79 per hour or per event. I apologize, not an hour, but per event. That those events are reimbursable for behavioral health services in a rural health clinic and in an FQHC. Those activities might be $84, $85 an hour or event that is reimbursable for behavioral health services for an FQHC. You also could have an accredited school-based health center. Again, different types of entities may manage those particular settings. It's attached on campus oftentimes. Many times it is limited to providing services in the clinic location, but being on campus and oftentimes attached to a school gives some flexibility in what that looks like. For the provision of services. And many times students can walk straight down to the school-based health center without even leaving campus, and just like going to the office or to the cafeteria or something like that. Oftentimes we will see an integrated care model here in the co-location of services and perhaps more advanced integrated care in this and rural health clinics and FQHCs. But that integration with physical health with licensed mental health providers. Those licensed providers are the ones that are providing services within a school-based health center. This does use a fee-for-service payment system. That payment system may result in different types of rates. And so you can see different CPT codes that are available here. But somewhere, $122 an hour is the state max. For an evaluation or diagnostic assessment, or 90837, $183 an hour for that particular service, or $91.58. I apologize. $183 is the maximum amount possible if you had 2 units of that. So the unit price is $91.58 for a typical therapy type of session. or 122 for an intake or psychological or diagnostic evaluation that is available to them. And of note is in any of these that you see state max, that's the maximum allowable. And so it depends on, like, you can't, an entity cannot charge Medicaid more than they charge others for other types of services. And so this is the state max. So that's the maximum amount. But whatever that entity is charging per those CBT codes, et cetera, that is their rate. So if I charge $100 an hour, I still need to charge Medicaid the same thing for 90791s or 90837. That $100 an hour would still be the rate, and it may not match the state max, and that's okay. Within these entities, all three of the entities as described, this is where an assessment will occur, a service plan or treatment plan will be developed, diagnoses will be created, typically through using DSM codes or ICD-10 codes. All these services are delivered by licensed practitioners, and a unique aspect of it, all of them have to be within the approved clinic location or site for those services to be reimbursable. All of these organizations within their site will also provide crisis management type of supports, perhaps case management under as attached to some of the psychotherapy work that's happening, but those services are available. The primary service we're going to get within these organizations are individual and family group therapy on site using evidence-informed, evidence-based practices. And what's unique is seeing the integrated care with primary care services that includes prescriptions for psychotropic medications that might benefit our youth or our students, but getting these prescriptions and getting training and monitoring of the administration or use of these medications. Next are community mental health clinics or centers and behavioral health clinics. They are oftentimes very similar and have similar regulations involved in this. There's also a group of sole proprietors that can also take Medicaid. These are individuals that would fall under this same similar guidelines for this. In community mental health centers and behavioral health clinics and sole proprietors, for Medicaid, services can be provided in the clinic or in the community. So services can be on-site in schools, can be in homes, can be at public libraries, can be at the park, can be anywhere that youth may be at. So we can really meet them where they're at. Now, this type of entity may also manage a school-based health center as well. That's possible. This one has a unique aspect of which there's some strengths to it and there's some weaknesses to it. Variable credentials as provider types, and I'll go over that here in a second. This one uses a fee-for-service model, with the exception of a couple things like care coordination service organizations or a certain type of case rates that are available in special circumstances. So when we're looking at Medicaid recognized staff types, there's a lot of variability here, whereas all the other entities I just described, a licensed provider would be the provider of these services. When we get into these in these organizations, we can have a licensed provider that's there, but we also might have a master's level provider, a QMHP, qualified mental health professional, that has a master's degree or 5 years of experience with a bachelor's degree under supervision doing mental health services. Or it might be somebody with a mental health professional credential, and that's typically a bachelor's level, but may also be a different level with certain types of certifications or extensive experience, or oftentimes both that may be there. Also an RSA, a Rehabilitative Services Associate. This provider is typically someone who's trained and has background check, things like that, but they are 21 years of age with a high school diploma or equivalent. And so these are unique provider types that are not available in many other types of settings. I think some of the other settings, community health workers might be a potential different type of provider that may be providing services through their programs, but many of those are not Medicaid reimbursable through their regulations, but through these, those are Medicaid reimbursable. Prescribers can be here, psychologists can be here, peer providers can be here, peer support workers, family peer providers can all get reimbursed through Medicaid. Psychologists are on here because there may be certain types of test administration, psychological evaluations that do require that specific licensure to be able to implement. So the good and the bad is, or in my opinion, the good or the bad is that one, you may not know the exact quality of the provider or credential of the provider. And credentials sometimes mean quality and sometimes they may not, but the credential of the provider by just the organizational type here, like you would with the other organizational types. And you are not limited to only licensed providers that are licensed at the clinical level that there's more of a shortage for. And so, again, you can find yourself kind of with mixed review on what that is. And again, sometimes that can work out in favor of the district, and sometimes that can work out against the district. Within these organizations, there is a requirement for an integrated assessment and treatment plan. This is the IMCANS, the Illinois Medicaid Comprehensive Assessment of Needs and Strengths. This is required at the initial visit or initial contact that ends up happening, with the exception of a few things like crisis management services or case management services for a short amount of time, that there are some options like that. And then every 180 days, every 6 months, there's an update to that assessment that ends up happening. We do end up finding ourselves, right, we have to diagnose. There is a service plan. We can use preventative diagnoses. So it might be for children that child may not meet the full criteria, but we can use the preventative diagnosis enough to be able to justify to Medicaid that there's medical necessity and the provision of services can happen coming through EPSD, the early periodic screening, diagnostic, and testing, or in treatment. EPSDT kind of drives this earlier intervention without a full diagnosis whenever it comes to providers and these provider types. Services may be delivered by anything from a mental health professional, qualified mental health professional, or RSA, et cetera. But all of them are overseen and supervised by a licensed provider. And so there's oversight in that provision of services. Here, I want to show what the rates are for Group A services. So if we're looking at integrated assessment treatment planning, that's about $33 on site. On site for a quarter hour. So, you multiply a quarter hour times 4, and it's about $132 an hour for reimbursable services. Not that services have to be an hour, but that would be what it would translate to. Then you get into other things like community support and case management services, medication training. Those types of activities are very similar at about the same rate for a master's level provider. And then there's lower rates for a bachelor's level provider or mental health professional, and then lower rates for an RSA. And there are some activities like counseling and assessment and treatment planning that someone that is at the RSA level cannot conduct those particular practices or activities. Here we can find crisis intervention services. That can be an immediate response to a crisis or decompensation in some way. That can be provided anywhere. So it can go where the client is and go to their home, go to the school, et cetera. And many of these services can be provided in schools without any type of challenge for Medicaid reimbursement. Of course, this is very similar. Therapy and counseling, psychotherapy, some of the most effective treatments. All of these entities can do this service, individual, and then you could also see family and group therapy, things that might be needed for addressing the whole child or the whole person when we're looking at providing mental health services to our kids and our students. Also, so a clause is that you can provide services without an IMCANS if that person's a licensed at the clinical level. So a licensed clinical psychologist, licensed clinical social worker, licensed clinical professional counselor, those services can be provided without needing that intake for up to 8 sessions. Similarly, consent can vary too in each one of these of what is it active consent, passive consent? Is it each one of these entities may be a little bit different? Can the youth 12 and older consent for their own services for a certain number of sessions versus needing parental consent for all services? That can probably vary from different types of organizations, but also vary from maybe the same type of organization, but one organization to another as far as what their policies, their procedures, their practices are. Another service type is community support. This is all about skill building, social emotional functioning, coping skills. It can be skills groups. It can be individual skills work that is overseen by a licensed professional of the healing arts or a licensed clinical provider, and it be available. Some of these organizations also provide prescription services, and you might get psychotropic medications from these providers, and there might be medication administration, medication monitoring, training on how to use that medication and use it effectively so that you have the best outcome for those services. Lastly, are case management services. This includes mental health case management, which can be helping identify and researching and identifying different resources that are out in the community that youth or families might benefit from, helping them complete those applications or completing certain applications and processes for them, but also will include client-centered consultation. So when we're communicating amongst entities and organizations, that conversation that ends up happening can also be a Medicaid reimbursable activity. And then transition linkage aftercare. So any youth that comes out of the hospital, there's a specialized coding system that we can use for that activity to occur. Additional Group B services are crisis intervention services and mobile crisis response team services. As you can see, there are different rates. Mobile crisis response is oftentimes an event. And so that event billing is around $402 per on-site event or $474 per off-site event. There are other types of screening and other types of services that are also available that could be services that our students may benefit from. Some of the history of screening and assessment and support services, or SASS, that now is mobile crisis response, is that we saw this kind of the late 1800s. We were providing these types of supports and activities, typically grant-based for high needs youth in crisis. Over time, we've seen these changes that are happening. And as we're moving, or as we're seeing kind of the need for stabilization within the community, we are seeing more and more investment in intensive community-based services and supports. So there's mobile crisis response. This aligns with the CARES hotline, which I'll talk a little bit more about. There's crisis stabilization that can be the follow-up for that, or crisis intervention team services that is more intensive and complex types of supports with multiple responders and or providers on the team. A couple of points about mobile crisis response is that in every what's called designated service area, there is a care coordination service organization with a mobile crisis response team. This team does provide services, crisis supports 24/7 to help respond or de-escalate or mitigate those crisis situations with some determination on what is the best course of action, working with the family on that decision. This includes providing services, crisis response services, after CARES hotline calls end up happening. So if in our school district, if we do suspect a crisis, we call the CARES hotline, and then the CARES hotline will relay that to the appropriate team that is the designated team for our area, for our community. And then within 30 minutes, that referral is supposed to happen. And then a mobile crisis response team member or team is supposed to show up within 90 minutes of that assignment happening. During that time, there will be screening and questions to determine the imminency of the threat, and threat to themselves, threat to others, or some type of psychiatric crisis of some sort. And so they will do this using the Illinois Medicaid Crisis Assessment Tool, and then respond, provide some immediate, perhaps crisis prevention planning or supports, and then start providing some follow-up. But a decision is oftentimes made at this point between psychiatric inpatient care or community stabilization. More and more, our system does support and want to support community stabilization when it's possible, when it's feasible for our youth. Oftentimes, even if I go on vacation somewhere, as an example, where vacation can seem amazing and great, but then I eventually come home to the same things that are happening. I still have the same job. I still live in the same home. Still have the same stressors that were there before. And so sometimes it's helpful, and sometimes it ends up being just more of a pause or a delay for the challenges to come back. But that is to be determined with that team, with the district involved in that process as well. But we should be seeing, and we can provide feedback and things like that, that we should be seeing a quick response within about 2 hours or so when we're calling the CARES hotline. When we find youth that may be repeatedly experiencing crises or maybe have been hospitalized multiple times, a referral or consideration for the Family Support Services Program, or FSP, might occur. During this time, there are extra supports and extra resources that are provided to families to help them stabilize, help them be successful, and assistance with the application for potential residential treatment that may be more long-term care for institutional supports than an inpatient hospitalization that could be somewhere between 3 and 14 days, whereas then a residential treatment could be 6 months, 3 months, 6 months, a year, or multiple years. And so this application process can oftentimes be pretty challenging, and there are many things to try first before going into residential treatment as an option for that level of care for that particular youth. And so there's a lot of extra therapeutic supports, family support that's provided. There's care coordination that's provided during this time. And if through all these things, if by the time the application comes up as eligible, if we have not found a way to stabilize the family at that point, then a family will go participate in the level of care of residential treatment services. You can find a lot of information about this, about these particular services in the Community-Based Behavioral Services Provider Handbook. You can also see services in HFS and multiple handbooks that are out there that will give regulation, description of each of the services, details that maybe nuances, and also, get consultation, talk with providers if you're looking at partnerships in some way. What success looks like for all of the different entities that we just talked about and the district is improved functioning within the family, reduce stress within the family, reduce stress within the classroom, within the school system, a more stable living situation, especially if there's been out of home episodes where someone's been kicked out, locked out, or had to go to out-of-home placements, whether that's foster care, residential treatment, or inpatient care. Increased use of the best services and supports that we can offer in that, improved attendance at school and performance at school, improved involvement in services, and improved in well-being and functioning for our youth, our students, and then reduced contact with child welfare or DCFS hotline calls or law enforcement. These are all things that I think most of all of our entities and systems of care and all of the provider types I've discussed and the district, these are all priorities for all of us for our youth. Given all the things I've said here, one consideration is a community partnership a way to be able to expand school-based mental health services so that our students are getting more needs met through that partnership, through that collaboration, through an integration model. Some of the opportunities that might be there might be on-site therapy or counseling or care coordination or crisis response services, participating or coordinating in team-based high fidelity wraparound or intensive care coordination type of models to be able to support the youth. Oftentimes we may find, as we talked about before, where the capacity may be larger for tier 3 types of interventions for students that are in high need, that our partners may collaborate with services in office, in the home, et cetera, or working integrated with primary care providers or psychiatric with psychiatric providers that provide psychotropic medication prescriptions and medication and training and education, et cetera, or providers that can come into our school and provide services in the school in collaboration and in alignment with what the success plan is for our students. And so there can be opportunities here as we look at these provider types that also utilize Medicaid as a reimbursement option, so that we're able to meet the needs of our youth as they're coming up, and we're meeting that kind of like 5% is 80%, right? So 5% of our student population takes 80% of the resources and capacity. And so with that, let's share the burden. Let's, look at who are the right partners. And there are certain ways to do this. I wouldn't jump in without planning and assessment of who the right partners are and who the right entity is and who's going to be coming into my school. But it can be something that is an option. In our next part of this webinar series, we're going to go over care coordination service organizations and pathways to success services. These are going to be higher need, higher intensity types of supports and services that we can find our very highest need youth that are not in residential care, not in inpatient care, but still in the community, that those highest need youth, there are some programs out there that can help support them, that can be our top 5 kids that we worry about at night and worry about every day, or have to be concerned about what their behavior is going to be like day in, day out. There are some resources for that. We're going to talk about that in the next series. Stick with us, stick around, and we'll talk about that one. And then part 5 will be, where are the opportunities? What can we do? How can I maximize Medicaid reimbursement? How do I create these partnerships? What are some things to consider on creating effective partnerships? What ways can I help utilize Medicaid or get Medicaid dollars to support mental health services in my school? Stay tuned.